Hi, everybody. Welcome to the LACNETS live webinar, Sequencing of Neuroendocrine Tumor Treatments with Dr. Eric Liu. I'm Lindsay Judavine. I'm the Director of Communications for LACNETS, and this is...
I'm Lisa Yen. I'm the Program Director for LACNETS.
We'd like to thank our sponsors today, Lexicon, Ipsen, Sun Pharma, AAA, and Novartis for making this possible. We're going to mention a few tech reminders before we get started. One is to ensure that your volume is turned up on your computer all the way. And if it's still not working, there's a mute button at the bottom right corner of the video feed that you can click and make sure the mute is off. And then lastly, if you want to make the video screen a little bit bigger, there's a button to enlarge your screen full screen in the bottom right corner as well. And we'd like to mention some upcoming events that we have on our calendar. Tomorrow, actually, Saturday, July 25th, we have our monthly NET Caregiver Support Group. And this is going to be facilitated by Dr. Kimberly Shapiro. This is open to NET caregivers. There's limited spots available, so please make sure to register on our website, lacnets.org, LACNETS.org. And then also we have a weekly virtual NET support group, which is open to both NET patients and caregivers. This happens every Wednesday at 12 p.m. noon Pacific time. And you must register for this one as well, and our registration's on our website, lacnets.org. Lisa?
Thanks, Lindsay. We're really excited to announce our upcoming webinars. Our next webinar is Friday, August 28th from 10 to 11:30 a.m. Pacific time. It's a webinar on the topic health coaching, which is a passion of mine. Again, you'll need to register on lacnets.org on our website. So the reason that I'm so excited about this webinar is because oftentimes we focus on the disease. And as you'll hear today's speaker, Dr. Eric Liu, say today, his focus is to treat the patient or the caregiver, but really the patient and not just the disease. So it's often easy to get caught up with the disease, with all the medical appointments, with the treatments of the symptoms and all the scans. And this is an opportunity to focus on how you might learn to thrive while living with NETs. So we've created this opportunity to step outside of being a patient or a caregiver to being a person. And we see you as a whole person. So we really want to create the space to learn to thrive, to focus on other aspects of your life outside of NETs, to help you live with NETs. So this is an opportunity in our August webinar to learn what health coaching is, and to meet or to see our health coaches, and also to get a taste of some experiential activities such as visualization and yoga. So we'll again feature some patient stories, and you'll hear from a couple of NET patients and hear a little bit about their journey and hear how they've benefited from health coaching. So LACNETS offers free individual health coaching. It's an opportunity available to Southern California residents living with NETs or family members of those living with NETs. And these are individual one-on-one virtual sessions that you can do for up to 8 to 10 sessions with a health coach to help you on your journey of thriving. So you can check out our LACNETS health coaching webpage for more information. So I'm really excited about our September webinar, which will take place on Tuesday, September 15th with Dr. Edward Wolin. And Dr. Wolin is very special to us because he helped found the speaker series, and approximately 8 years ago, he was the very first speaker of our monthly speaker series. And so he's been involved with LACNETS. He used to be out here, the head of the Neuroendocrine tumor program at Cedars-Sinai, and now he's in New York City. And he's just confirmed that he will be our speaker in September, and the topic will be advances in neuroendocrine therapy. And also talk a little bit about COVID as well. Registration is coming soon, and so we're excited that he'll be joining us. We also wanted to talk a little bit about other programs we have available for you. And we already mentioned the health coaching. The other thing that is helpful for those, especially those who are newly diagnosed, is our Net Vitals tool. So it's a communication tool that that Dr. Dan Lee, Giovanna, and I collaborated on to create for NET patients, so that it's a document that you can download on the computer on our website. You can download, or you can print it off and then fill it out. And it has the basics of what's important when you go see your NET specialist, or to carry with you. So if you end up having to go to the hospital, you know the basics of your disease. And even if you cannot fill it all out, it highlights the things that you do not yet know, and perhaps things that you should ask your doctor. This is the basics and the most vital information about your NET disease, which is why we created this document, so that it can help you know the same language and get on the same page to make your appointment and your consultations more efficient. So we often talk about going to see a NET expert. We're getting second opinions, and this is a document that can help you prepare as you're going to see them. Another program that we have is NET Connect. So if you're looking for a mentor or to talk to another patient or caregiver that's a little further on the journey than you are, feel free to reach out to us and we can pair you with someone. Or even if you would like a little help on filling out your NET Vitals, we can also pair you with someone to help you along the way. We've written many educational blog articles, and so feel free to check those out on our website. There's many, including informational things on PRT. We have other blog articles that talk about programs we have and supportive issues. So we have a lot of content out there, both on our website, on our YouTube channel, and on the blogs.
Great, thank you, Lisa. We also have NET quizzes on our website. Lisa has actually created these NET quizzes based off of the NET Research Foundation's NetWise podcast, and you can it's a fun way to learn about NETs, so if you have time, check those out. Also, make sure you're following LACNETS on our social media channels. We have a Facebook page, Twitter, and Instagram. You can stay up to date on all our upcoming events, meetings, announcement, NET research, NET news, all of that. And then also, we have a LACNETS YouTube channel with 100+ NET videos, a lot of videos there, great educational resource. So make sure you check out our YouTube channel as well. And now I'm going to hand it off to Lisa, and she's going to introduce today's speaker.
Thank you, Lindsay. So I'm really excited to introduce Dr. Eric Liu. He's a well-known neuroendocrine tumor specialist and a surgeon at Rocky Mountain Cancer Center in Denver, Colorado. He's a graduate of Columbia Medical Center. He did his residency in New York City at New York Presbyterian Hospital and a fellowship in Uppsala University in Uppsala, Sweden. So it was during his training there, during his fellowship, that he learned quite a bit about neuroendocrine cancer. That's where he was introduced to the gallium-68 scan and PRRT. So many of us know Dr. Eric Liu for his sense of humor, his patient-centered philosophy. So he'll often say that his focus is to treat the patient, not the disease. He finds that giving the patient time and respect is critical to developing a sense of trust, because it's a team effort with the patient in the center. So he's told people many times that he values the quality of life as highly as the quantity of life. And therefore, he uses every resource at his disposal to address the problems. When treating neuroendocrine cancer, it's absolutely imperative to approach it with a multidisciplinary approach, because it crosses into many different medical subspecialties. So without further ado, we introduce to you Dr. Eric Liu.
Hi, everyone. Thanks for joining us. Thanks for LACNETS for putting these speakers series together. It's really great, and all of our supporters. Of course, it's always a wonderful opportunity to connect and talk with everyone, our whole community, about what neuroendocrine is, how I think about neuroendocrine, and you're going to have some some speakers come down the pike who have some interesting, exciting things. So the way we're going to structure this is I'm going to give a talk first, right? So I kind of just present these slides, and I think it's being recorded, so you can probably watch it later. But most importantly, I'm going to go through these slides, and then afterwards, we'll have plenty of time. So I blocked out the whole afternoon, which may be a good or bad thing, but I blocked out the whole afternoon for you guys so that we can spend time and talk. So it's like a question and answer session. So the last time I went to the LACNETS was, I think, last year or the year before. I gave some tiny little talk, and then we just sat and talked for, I think, another hour and a half or two. So, this is a time that hopefully I can give you some more information. Now, the one thing I do want to say is I would prefer, if you're okay with this, not to say anything specific about any individual case. So if you've got like a generic question, and even if it applies to your case, it's fine. But the reason I don't love to do that is because I don't love to give a bad answer without studying your case. So any of you all who have come to see me know me pretty well. And I like to sit and study and talk and look at your scans so I can give you a good opinion rather than just giving you some Twitter tweet, 255 character answer. So if you don't mind just kind of keeping that in mind, I'm happy to answer whatever general questions you have, and hopefully we'll be able to have a good time, okay? But do ask a lot of questions. I think it's always a good opportunity for people to learn, and we'll go from there, okay? So I'm going to talk about sequencing of treatments for neuroendocrine tumors, but maybe a little more than that. I think we probably have a few people who are newbies who are here to learn. So I'll go back a little bit, but I'll kind of talk about my philosophy for thinking about sequencing, because you'll see what I mean in a second. Okay, so let the virtual happy hour begin. As long as we're together, it is a happy moment. So cheers to all of us. Now, I will let you know that there is no vodka in this drink. This is just water. But you, my friends, are allowed to drink whatever you want because I'm not watching you, so it's okay. In fact, feel free to comment at the bottom there. What I really want to know is how hot and humid and disgusting it is where you are. Because I live in Colorado, and there's nothing but blue skies, and there's no humidity. So I just want to rub it in to all of you people who cannot walk outside because there's so many mosquitoes and it's so hot, okay? All right, so, for those of you who have not been to my clinic, this is what my clinic looks like, okay? Just so you know, you have to come up here, you fly, we're up here in the Rocky Mountains. This is my patient, his name is James B. And we'll just use that as our, for HIPAA. And what he has there is a bag full of Imodium, right? So you know that this patient has neuroendocrine and carcinoid because he is well prepared. He's well prepared. I am kidding, of course. This is not my clinic. This is James Bond. He does not need any HIPAA issues. This is actually my clinic right here. And sometimes in the winter, some of you come and it looks just like this. But it's really quite beautiful. Most of the time, it actually looks just like this. This was a picture actually of the very first day I came to work. And I looked up and I saw this moon up here and I thought, oh, that's a good sign. But I could not believe how blue the sky was. It is a neat, neat place. So we welcome all of you to come anytime you want to come down, okay? Okay, so let me tell you a little bit myself. So Lisa kind of gave you my little spiel, but basically, I'm a general surgeon. So I was trained in New York City, and I did all my kind of general surgery stuff. And then I was very, very lucky and got recruited down to the University in Nashville, Tennessee. And then I was sent over to Sweden to do my training, right? So clearly my chairman hated me because, here's the height of Denver, which is near Rome and Barcelona. And he sent me here to Uppsala, Sweden, which is the same latitude as Uranium City of Canada. So just to give you some context of where he sent me. But I'd never been to Sweden before, and I couldn't believe it. It's so pretty. So if any of you guys can go, you should definitely go. So we went to Uppsala, which is a college town just outside of Stockholm. So it was me, my wife, my two little ones who were just 2 and 4 months old. And this is Sweden. I mean, it was gorgeous. It was fun. And that building is like 1,000 years old, that church is. So it was a neat place. And I learned so much. So I was very blessed. I got to work with an amazing gentleman named Dr. Kjell Oberg, who is kind of one of the founding fathers of the whole field of neuroendocrine. I mean, when he first started, it didn't even really have a name. So we spent several months with him, and we did surgery, and I learned about all the different things that they do over there. And it really gave me a jump start to my career because I actually got some training. And just so you understand, the reason that my chairman sent me there, because I didn't know anything about neuroendocrine, right? I mean, well, what did I know? I didn't know anything. He said, don't worry, Eric, no one really knows anything about neuroendocrine, but I know this person who can teach you. And so he sent me to Sweden, and that's where I learned. And so it's a real blessing to have been able to work with such talented and amazing people. So that they had an amazing neuroendocrine clinic. But the nice thing about it is that neuroendocrine has really kind of changed over the past, this is 10 years ago. I can't believe this picture is 10 years ago. And neuroendocrine's changed a lot. So a lot more people are interested. So it's not just one clinic in the world anymore. So hopefully there's a lot more opportunity for our patients to be well cared for. This is just another picture. So in the past 10 years, this is a picture of our team when we were at the FDA getting the gallium-68 scan approved. And so a lot has happened in the past 10 years. So it's very exciting. And you'll hear about all that stuff next month, hopefully, with Dr. Wallen, but hopefully I can touch on some of it now. So let's back up just 1 second and let's just talk about the basics of neuroendocrine. I know everyone has probably heard this before, but for some of you who have not, hopefully I can present it in a way that you can understand it better. So what is neuroendocrine? So neuroendocrine is actually a much more complicated thing than most people think, right? So when you think of endocrine means hormones, right? So people think of like a thyroid hormone or pituitary, gland or an adrenal gland. And those are glands that make hormones. That's what they do for a living. They make thyroid hormone, right? But in fact, most of the hormones that are produced in your body are actually produced other places, like your lungs, like your guts, like your pancreas. And people don't think about that. And they're teeny, teeny, tiny little cells that express all these hormones to help you function. They help move air through your lungs. They help you cough when you need to cough. They help control water flow through your guts. They help control insulin. So they have a lot of really magical things, and they're so quiet and in the background that you don't have to think about them. Except when they go bad, they can sometimes turn into these kinds of cancers. So neuro, because they're smart, and endocrine, because they secrete hormones. Does that make sense? Now, they can be found anywhere, right? And the problem is you can't see them through your eyes. You can only see them under the microscopes. They come from the lungs. Like I said, they come from the gut. They come from the stomach. They come from the rectum. They come from the pancreas. They go to the liver. They can do all these things. And when they secrete hormones, they can secrete things like this. They can secrete serotonin, they can secrete insulin, they can secrete gastrin or glucagon or VIP or somatostatin or histamine. I mean, it sounds like a lot of stuff, but this is probably 7 of probably 7,000 different hormones that your body produces. So just understand that we are talking about the very, very, very tip of the iceberg when it comes to our understanding of these things. But we do our best and we actually understand a fair amount, but there's still so much more for us to learn. Anyway, the one thing that's very important about it is all of them express something called a somatostatin receptor, okay? So there's a little bit in the weeds, but a somatostatin receptor is basically a little receptor. So it docks hormones. Like think of it like a lock and key system, okay? So it's like the lock and the key comes in and then it does stuff, right? And the reason I wanted to bring this up, I know it's a little scientific, but I want to bring it up because you will see it over and over and over again. We're very fortunate, actually, that in neuroendocrine, we have this receptor that we can use for diagnosis, we can use it for treatment, and we can use it for even more advanced treatments. So there's it's good for you to understand what that means, okay? Especially when you see a doc maybe who doesn't quite understand what that means, okay? So it's pretty important. Okay, so a few definitions because the wording can be quite complicated. I'm sure any of you who have been around long enough have seen how difficult just the words are. And what you might find out, is if you're working with kind of a local doctor who's maybe not so familiar with neuroendocrine, maybe they're a breast cancer doc or maybe they're a lung cancer doctor. If they're not so familiar with neuroendocrine, they may not be quite so familiar with even the terminology. So let me explain it to you. So neuroendocrine tumors, remember neuro-smart endocrine, come from these diffuse, so kind of all over, these diffuse cells that turn into tumors that can secrete many types of hormone. Okay, so that's generally what a neuroendocrine tumor is. And that is actually the modern umbrella term that we use, so neuroendocrine tumors, the more modern term. But about 100 years ago, a little over 100 years ago, they started with this term called carcinoid, which means like, cancer-like, it's what it means. It's still a term that you'll hear. It's still a term that's used. We tried not to use it so much because when a lot of people hear the word carcinoid, they think back and they think, oh, isn't that some kind of benign tumor or something like that? It is not. It is not a wart. It is not a birthmark. I mean, generally, but it's an older term. So now what they are is it's a neuroendocrine tumor that comes from a tube. Okay, so either a breathing tube like this, or a digestive tube like this. Does that make sense? So it's a slow-growing tumor of the GI or bronchial lung tracts that derives from enterochromaffin, just a fancy name for a cell, that frequently secretes serotonin. Not always, but frequently. So a carcinoid tumor is a neuroendocrine tumor from the lung or the gut. That makes sense? That's essentially what it is, the digestive tract. So that'll kind of help you get a sense of the terminology. And you might have to explain that to a lot of people over the next, year across your journey, including many, many medical professionals. So keep that definition in mind, okay? Okay, so let's talk about NETs for a second. So you can see, I mean, neuroendocrine is complicated. I know I'm preaching to the choir here, but a lot of people don't think it is. Like, oh, neuroendocrine, that's no big deal. But then you're like, well, people are like, how can you possibly make a career off of neuroendocrine, right? That's all I do, essentially. And then my wife's like, well, how are you going to make any money doing neuroendocrine? Right? And you'd be surprised because neuroendocrine is very, very complicated. And there are very few people in the world who really know all of the little nuances and can sniff out all the differences between neuroendocrine. So take a look at this slide, which I've had for like 10 years now. Basically, neuroendocrine is essentially divided into two big branches, right? So one is these pancreatic neuroendocrine tumors, which can produce a whole bunch of different things. And then these other neuroendocrine tumors, again, sometimes called carcinoids. And see on this slide, there's already like 15 different things. But the problem is each one of those has like 3 different branch points, and each one of those has 3 different branch points. So by the time you're done with neuroendocrine, you're talking about probably like 75 to 150 different kind of flavors of neuroendocrine. So it can be really complicated. And of course, you want to see someone who understands all the different nuances, because you wouldn't want someone to treat your sore throat the way they would treat an appendicitis, right? I mean, when I say something that obvious, you're like, of course not, that's ridiculous. But would you want someone to treat your lung neuroendocrine the exact same way they would treat your rectal neuroendocrine? I know they sound similar, but they're not. And so that's the difference. And that's why always it's important to see someone who understands it. So this is kind of what it is. So neuroendocrine is a little bit like Baskin-Robbins. And I am young enough to remember when Baskin-Robbins, or old enough to remember when Baskin-Robbins was only 31 flavors. And nowadays, I think they're like 75 different flavors, which is a lot closer to neuroendocrine. And that's kind of how neuroendocrine is. Tiny little differences between these things, but they are all different flavors. And if anyone comes to Colorado, this is the cannabis flavor. Okay, so make sure you come by and try that. And then there's a Cheeto flavor right next to it. So they go together, Cheetos and cannabis. Okay. All right. And you have to understand that neuroendocrine is not a disease without a face, right? It sounds rare. Oh, how could you possibly have neuroendocrine? That's so rare. Well, these are people who had it. This is Dave Thomas. He had neuroendocrine. He was the founder of Wendy's, the hamburger restaurant. This is Audrey Hepburn. She had kind of a version of neuroendocrine, and her stomach hurt for a long time. This used to be the most famous person who had neuroendocrine. This is obviously Steve Jobs, and he had pancreatic neuroendocrine. But now, the most famous person to ever have neuroendocrine is now Aretha Franklin, right? She had neuroendocrine pancreatic cancer. And of course, the real thing is, what is that? And it's true. What is that? Most people don't know what it is. Most medical people don't understand it. And just to give you a sense of it, so I'm not that old, I don't think. I've been around for a while, but I'm not that old. And when I went to medical school, I had neuroendocrine. It was not called neuroendocrine. And I had 45 minutes in 4 years of study. That's what I had. 45 minutes in 4 years. So I really don't blame anyone for not understanding neuroendocrine. But then it kind of modifies how you want to think about things, right? Okay, so let's talk a little bit about sequencing, which is a little bit vague. But let me tell you about my opinions about sequencing and my philosophy, okay? So like Lisa said, these are the only 2 real goals that I have, right? When you boil things down to very simple concepts, and I am not that smart, right? You can ask my wife. She will tell you I think I'm way smarter than I really am. So what that means is there are two real goals that I focus on. And if I can figure out these two things, I can usually do a good job. And all I really want to do is how can I help people live a better life, right? And if I can do that, that's my first priority, because sometimes I cannot predict how long someone's going to live, right? I mean, I just can't do that. But if they're doing pretty well, then how can I help them live a longer life, right? So it's those two goals in that order, okay? And I believe very strongly in that. So how can I help them live better? Are they struggling with their medical issues? Are they having pain? Can they not go outside because they have to go to the bathroom all the time? I mean, those are the kinds of things. If we can make a little bit better, then people can enjoy their time here on Earth, okay? And hopefully if you kind of keep these two concepts in order, I think the whole talk will make a lot of sense. All right, so what is step one? Okay, so neuroendocrine, oh my gosh, what is going on? I'm not sure what's happening. People tell me this is cancer. Well, I think the first thing you should do is you should go see a neuroendocrine specialist, okay? Now, I feel very, very strongly about this because it's not that they're going to take over your care or they're going to be, the most important thing is you want someone to help sort out all the issues and help to explain to you so you understand the disease better. So I feel very strongly you should go see a neuroendocrine specialist. I will say that 1,000 times if you want me to. But it's really important because just like I told you, there are subtleties in neuroendocrine that a lot of people don't understand. And again, most people get 45 minutes in 4 years of training or 10 years of training or whatever, and they don't really understand neuroendocrine. So you should definitely go see a specialist. Now, not all specialists are the same, right? And there are different, kind of lists and recommendations and things like that. So you may want to think very carefully about it. But you'll see, LACNETS has lists of people, people who give a lot of talks and people who are kind of around, people who support the community. Those are the people who probably see the most neuroendocrine, and it's the only way to really understand the disease. Like for me, once you've seen it 2,000 times, you get a really good sense of what's going on. Do I see new things all the time? I see new things all the time. But those are the kind of people you want to see because they have usually a little bit of a deeper understanding. So please, just include a neuroendocrine specialist in your team, your healthcare team. Okay, step 2, right? What you really want to do is do a complete workup before you jump into anything. What frequently happens, unfortunately, and I'm sure a lot of you have this experience, is that people will say, oh, you have neuroendocrine. And then all of a sudden they'll whisk you away to surgery and let's say you have to have surgery tomorrow or next week and stuff like that. Well, that's not true. I mean, if you're sick, it's a different story, of course. But if you're not sick and you can just take a moment to take a deep breath and figure what's going on, you're much better off doing all your homework, crossing your T's and dotting your I's prior to cutting, because you want to make sure that you know all the information before you do anything. So you want to do a complete workup. Now that depends. What is a complete workup? But you want to do that as much as possible because you want to measure twice and cut once. I'm a surgeon, right? So I always try to make sure I know what I'm doing, make sure I can, do the best job I can when surgery comes so I don't have to redo it. So like half the time I have to redo people's operations. And not that it's a big deal. I mean, it happens a lot, but if we can do it right the first time, it's better for you, right? It's better for you. So we think about that. So what is a complete workup, right? And again, this is just a couple of things, but you want to make sure you get all the right labs drawn, right? So you want to make sure that you have all the markers so you know what's going on. You want to have a really good quality imaging. So you want a good quality, usually a CAT scan of some sort, usually some kind of chest, abdomen, pelvis, something like that. You want to get a good biopsy and a good pathologist. They can take a little piece of it so they really understand what your neuroendocrine is. And then usually you want to get an MRI of the abdomen so you can kind of take a good look at your liver, which is a common place for neuroendocrine tumors to go. And finally, you pretty much always want to get some kind of a functional test. In this case, for neuroendocrine, you want to get something called the gallium-68 dotatate PET CT, okay? It's not available in every neighborhood, but it is an important test. And if you can get that test before you have surgery, that's really much better. So these are just a sampling of some of the things that you want to do and you want to get before you start embarking on surgery and things like that, okay? Because think about this. So this is just an example of imaging technology. If you had the scan on the left, you would see that, oh yeah, maybe there's this tumor here right in the middle. Oh yeah, maybe you should have surgery for such a thing. And sure, that would be reasonable. But if you're going to cross all your T's, dot all your I's, and do all your homework, you would have actually had this. right? And then you're like, oh, wait a second. This is the same guy. These two scans are only a month or two apart. So you have to see there's a difference in technology. So this makes a big, big difference. So as best you can, do your homework first. Okay, so now that we kind of got all those preachy things out of the way, how do we think about sequencing? So let me explain kind of what the sequencing means and why Lisa asked me to do this. Sequencing, we have a lot of things that we can do to you, okay? You can certainly do some kind of surgery. You can do some kind of radiation. You can do some kind of medicine. You can do different kinds of medicine. You can do some kind of immunotherapy. You can go back and do some more surgery. So there are a lot of things that we can do. But the question is, what do you do and when do you do it, okay? So typically for other types of cancers like breast cancer or colon cancer or lung cancer, there's a very fixed what we call pathway. Pathways are a very important kind of concept for oncologists. There's like this and this and this and this. So usually we try to do some kind of surgery, right? Because you want to get those tumors out, right? And then the next thing we do is usually some kind of radiation. You know, not every cancer uses the same pathway, but something like that. And then usually you go on some kind of first line chemo, and here's what the pathway, and the second line chemo, and then you'll have some kind of third line chemo. So it's a very straight line. And then either you live or die. I mean, that's kind of how cancer works, right? I mean, and I'm oversimplifying this, so I apologize. But this is kind of the way that people think and the way that things work in kind of classical cancers. So if you, for example, if you go and look at the various treatments or chemotherapies for lung cancer, you'll see approved for first line, approved for second line, approved for third line, because that's all they're approved for, right? So you have to go in this path. The problem is that this doesn't really apply to neuroendocrine. Neuroendocrine is really quite different. I think of neuroendocrine as more like a web, okay? So it's kind of like, well, you could go this way or go this way or maybe this way depending on this or depending on that. So it's like a web of treatments. And that's why it really takes a neuroendocrine specialist to think about it, because there's so many different kind of scenarios and different types of things. And remember how so I can only think of it as really sequencing. I think of it as what is appropriate and what's the appropriate kinds of treatment, right? Because there are 75 flavors of neuroendocrine or 150 flavors of neuroendocrine. So each one is a little bit different. So there's kind of a web. So, yeah, I mean, some people would say, okay, well, if that's the issue, well, maybe then really what's going on is you're really just playing whack-a-mole with neuroendocrine. Well, that actually may be kind of true. There's some truth to that. And so sometimes things will come up and they can cause a problem, so you want to whack that mole. And then something comes up, you want to whack that mole. But, you know, if I could keep whacking those moles for like 10, 15, 20, or 25 years with your disease, I think you'd be pretty happy with me, right? Does that make sense? So it's a little bit of a different philosophy from the classical kinds of cancers that most oncologists take care of. So it's just a different way of thinking, it's a different approach, it's a different thing. So which is why I always think having a neuroendocrine specialist on board is really helpful. Okay, so tell me if this is what your first appointment was like. Oh, you're diagnosed with this cancer. Oh, it's stage 4. Well, you could do surgery, or we could give you a shot, or you could have radioembolization, or there's this new therapy called PRRT. I've got this other thing called Afinitor, or maybe Temodar, or maybe this other kind of surgery. We have another medicine called Sutent. Or we have this radiotherapy. Maybe I should give you some chemotherapy. There's some chemo. Did you kind of feel like this when you were first diagnosed? You know, just people just throwing all these things at you. Well, that's kind of how neuroendocrine is, you know, and I've seen it before. I've had this conversation. I've done this thing. I've just like laid all this stuff on people, and you could tell sometimes their eyes just totally wide out and they just blank out, and it's not fun. I understand, and it's certainly not fair. And so this is why seeing a specialist who can kind of simplify these things for you can really help you, I think, because it is very complicated. And what I've learned too is, because, you know, I work with a lot of the other neuroendocrine specialists. They're wonderful, wonderful people. They're very, very smart, like Dr. Wallen and Dr. Lee, who I think who presented last month. We just don't agree. We just don't agree. And because there are so many different options, you can kind of do so many different things, it's hard to really know what's always right. So this is how I approach it, right? So my question is, so how do you decide on a therapy? Because ultimately it probably does come down to you. Everyone always asks me, well, what if I was, your mother or your wife, what would you do? And I tell them that's hard because everyone's very different, right? But I try to guide them through this process. And so I say, well, how do you decide on a therapy? Well, essentially you want to make sure you understand very clearly what are the risks and what are the benefits. And when you weigh those two together, okay, then you can kind of get a sense of what is the right thing to do, okay? So the first thing I think, well, what is my goal? What am I trying to achieve for this person? Okay, well, it's either one or two. Am I going to make this person's life better, or am I going to try to help them live longer? Those are the two things I want to do. So am I trying to improve their symptoms, right? Are they having so much diarrhea that they just can't function, right? Which is, I'm sure many of you have experienced that. Am I trying to remove their tumors, right? So am I going to give them something that makes them shrink, or am I going to try to make them go away? Am I just trying to shrink them so that I can get them under control? Am I trying to prevent complications, right? So frequently what happens is people have these issues, right? You're not supposed to have a tennis ball tumor where it doesn't belong, and then it causes some problem. And it may not be causing you a problem today or tomorrow, but it might cause you a catastrophic problem in 2 or 3 years. So I've seen this before. I've learned this lesson the hard way. And so I think about that. So is that what you're trying to do? So once you kind of understand what it is that you're trying to achieve, then you can start to think about these things. Oh, I'm sorry. And of course, am I just trying to stabilize the disease? Do I just want it to be there so it doesn't bother you anymore? Because every day you can live with a neuroendocrine tumor is a day you'll be alive. And if there's more therapy that helps it, great. And if there's less therapy and everything's okay and you can still live, great, then that's terrific. Okay, so what do I have in the toolbox, right? So there's actually a bunch of stuff. You saw it kind of swirling around, right? And this is where you will hear 7 different opinions from 7 different neuroendocrine specialists, right? And no one's wrong, and yet no one's quite right. So the way I think of it is like this. Basically, neuroendocrine, unlike, say, lung cancer or pancreas cancer, where you might be driving on the side of a teeny tiny little road on the side of a mountain, where if things go badly, you fall off the cliff and you die. That's basically what it is. Neuroendocrine's a little bit different. Neuroendocrine is kind of like a big super highway, okay? So it's a big super highway that's this wide, right? And my goal is to keep you going straight on the highway. So if you veer a little bit left or right, okay, I mean, that's fine. You can probably get away with it, okay? But I don't want you to veer so far over that you fall off the cliff and then I got to dig you out of the ditch, okay? That's the problem. So as long as I can keep you relatively healthy and going straight, then we are in good shape. And that's always the goal. So sure, that might require some medicine or that might require some surgery. And you're like, well, I feel perfectly fine. I'm like, yes, of course you feel perfectly fine. But there will be a day when you don't. And I'm trying to push that day as far out as possible. Okay, does that make sense? Okay, so one of the things that you have is surgery, right? And so I do this for a living, so I'm a big proponent of it. And the reason is because I've seen the benefits of it. And I think it's really, unfortunately, underused. I think a lot of the medical people aren't so familiar with it. So they think, oh, it's very dangerous, you can't do that. Or, unfortunately, there are many medical people who are very pro-surgery, and then they just can't get the surgeon to do it because maybe the surgeon doesn't think it will help. But so if you have surgery and you're thinking about it, well, the goals would be, can I make all the tumors disappear? Okay, that certainly is a high priority. Can I prevent complications? And I'll show you an example there. And actually, can I help with the symptom control? So that actually might be very helpful. Obviously, there are real risks, right? So there's the operative risk. You could have bleeding, you could have infection, you could have all kinds of issues, right? So it's not perfect. And unfortunately, it is definitely not perfect because even if I do all the surgery, these little boogers, they keep coming up, right? So they just keep coming back. It's a microscopic disease. But the thinking is with surgery, if I can just set the clock back, right? So get out all those big fat tumors, get you all cleaned up, at least I can set the time back. And even if you sprout some new things, maybe they'll grow slowly so you'll still have plenty of time. Does that make sense? So you want to kind of do that. You want to set the clock back and get things cleaned out. So what's the first thing I should do? Well, I told you should get a net specialist, right? And then you should do a good workup. But the first treatment usually is you should cut it out, right? And then the next thing you should probably do is you should think about cutting it out again, right? And then the third thing you should probably think about is you cutting it out, right? Because neuroendocrine is a mechanical disease, right? You shouldn't have little grapes and balls and, you know, mandarin oranges where they don't belong, because they can cause problems. So you really want to try to cut those things out, okay? And that's not usually what we do with other kinds of cancers. For example, if you had a pancreas cancer and something in your liver, no one would do your pancreas surgery. But very frequently, we will go and take out the bowel and maybe part of the pancreas and part of the liver and the gallbladder to kind of get that whole thing cleaned out. Because in general, neuroendocrine tends to be a slow-growing disease. It's not always, but it tends to be a slow-growing disease. So if you're going to be around for 5, 10, 15, 20 years, I want to make sure I get your belly or your lung as cleaned out as much as possible. Okay, look. So this is what you can do. So this was a case in which everyone said you couldn't do surgery on it. So we did the surgery on it, and we kind of got all the tumors out, and the person's doing great, right? And if you want to see even more, I hope everyone had lunch, I guess, and you guys are hoping no one's eating lunch as we speak. Here's another example of the surgery. So you can see you can take a lot out. So even if the radiologist is too numerous to count, which sometimes can only be 12 or 15, sometimes you can go in there and get many, many more out than you think. It's not perfect. There's microscopic disease inside there. I know that. It will come back. But if I can get the big ones out and just leave the teeny tiny ones to be controlled by the medicine, then I still think I've done something good, okay? So this is actually what we call a complete response. You go in there, you respond, you get all those tumors out, right? So here is an example of where surgery must be done. So this is an intestine here, okay? So this is just a ruler across here. But this is an intestine that goes all the way around, right? This person's chief complaint was my stomach hurts all the time. Every time I eat, it hurts so badly. And this has been going on for the past 3 years. Does this sound familiar to any of you? I'm sure it sounds familiar to all of you, okay? Imagine if you had to get your broccoli salad or whatever you're having for lunch through this knot, right? This is literally your intestines tied into a knot, because right in the middle here is a neuroendocrine tumor that cinched it down. The fancy medical term is called a desmoplastic reaction, but all it does is it scars and it pulls, and you cannot get food through. No medicine, no PRRT, no embolization is going to fix this. You have to have this done by surgery. So this is why it's important to realize that this is an important tool for you. Again, not for everyone, not for everything, but you must remember that it's not something you should just abandon. And you can't figure this out on a CAT scan. You have to go in there and just actually physically get inside there and look. Okay, so this is not rocket science, right? I mean, I'm showing it to you. Just imagine getting your meal through that intestine. But here's another example of a bunch of liver tumors. Okay, so this is a lady who we did surgery on several years ago, and she's about 90 pounds, and I think about half of her weight was this tumor here. So we took out this left tumor here, and we took out these other tumors here, and she was totally clear for a long time. And I want to show you something. This is very interesting. One of these tumors is not like the other. Can you see that? Which one? It's this one, right? Why is it different? It's filled with jelly, right? So this is what we call a cystic neuroendocrine tumor, but cysts, which are fluid-filled cavities of the liver, are very common. The reason I knew that she had this as a tumor was because she had that gallium dotatate scan. So it turned out that the whole skin was all tumor, and the inside was made of jelly. So even from one tumor to the next, within a single individual, they behave differently. So even within the same person, you have different flavors, right? And let me just illustrate it here. So here's an example. This was a patient who comes from Houston, and he had these growing tumors, and the doctor wanted to start him on some more chemo and medicines and stuff like that. I said, hold on a second. You may need those things in the future, but now that's not the situation, because not all of your tumors are the same. And this is, in fact, what he had. What he actually had was a tumor that was actually filled with blood. So like a balloon, the cancer wasn't really getting any worse, but it was filling like a balloon. So it kept getting bigger and bigger. So that's what it looked like. And there you go, right? So it's just a shell. So those are the differences sometimes you can see. And when you do this every day, you see all the differences, the various combinations, the different flavors. Okay, so that's surgery. Hopefully you get a sense for why it's important. So let's talk about the one that probably all of you are on, the somatostatin analog. So either sandostatin LAR or somatostatin, which is octreotide, or somatostatin depot, which is lanreotide. These are two wonderful, wonderful medications, and they've been shown to help with symptom control and tumor control. So there are data on both of these for these kinds of things. That's what you're trying to do. Again, they're not perfect. It is a dart in your bottom every single month, and so it's not fun. But really, the problem is they're not super strong medications, and so usually the tumors will eventually grow through them. But they're really, really good at controlling symptoms because it's a suppressive hormone. So remember at the beginning, I told you about the somatostatin receptor, remember, which was the lock and the key system. Well, this is the key, right? And so the hormone binds to the receptor, it sends a message into the cell, and it tells all the cells, please be quiet. Please don't secrete so much hormone. Please don't torture this person so much. And that's the benefit of these medications. There are slight differences between the two, but they're in the same, what we call class. So called somatostatin analogs. So they're very similar. And each person, reacts differently. So it's always nice to have more options. But that's kind of what's going on. But they can usually help with some kind of tumor control, and they can usually help with some kind of symptom control. Then there's another kind of therapy called liver-directed therapy. So you may have heard different words. They're called bland embolizations, or sometimes called TACE. You may have heard that, transhepatic arterial chemoembolization. There's another one called radioembolization, sometimes called Y90. And that's to treat the tumors that are kind of mostly in the liver. And neuroendocrine not always, but mostly goes to the liver. And so you want to make sure that you can keep the liver alive. Because I tell people all the time, if I can keep your liver alive, I will keep you alive, right? So that's a very, very important goal. Again, it's not true for every single person, but it is very frequent. So can I make the symptoms better? Can I possibly make the tumor shrink? Can I possibly keep them stable? That would all be good. Now, of course, the risks are if you do radiation, you can actually cause radiation scarring to your liver. Sometimes you can lose some blood supply to the liver and have complications from that. You can actually do it a fair number of times, but there are a limited number of times you can treat it. And it always progresses. It always gets through it, okay, at some point. But if I can buy you a year or 2 or 3 out of it, that would actually be quite important. Okay, here's the new hot topic, PRRT, also known as Lutathera. I know for sure a lot of you have had this treatment. And what this is a treatment where you can actually inject radioactive hormone into you, right? So remember I told you the lock and key, right? So if you give it as a medicine, just what we call a cold medicine, it binds to it and it relies on the biology of the cell in order to do it. Well, I showed you that gallium dotatate scan previously. So all that is the same hormone with a light bulb on the back of it, okay? And you can then take pictures of your tumors. Well, what PRRT, which stands for peptide receptor radionuclide therapy, and the drug's name is Lutathera, what you can then do is you can then take a nuclear bomb and put it on the back of it, okay? You put it on the back of it, then you can actually give radiation as a liquid, and you get radiation from the inside out rather than outside in, okay? And it only goes straight to the tumors. It's not perfect, it has some side effects, but it is a great tool to have in the arsenal because it treats your whole body, right? Now, that does mean you have to have a positive gallium scan or octrea scan because you need the receptor, right? If you don't have that lock in place, then the key has no place to go. So that's what you want to make sure you understand. But if it does, this may be a treatment for you. Now, there are some risks. You can have some bone marrow toxicity because it's radioactive, right? So radioactive. In general, there are only a limited number of treatments that you can give, and eventually people progress. But for the small intestine, frequently people can have disease stabilization for up to like 4 or 5 years. And for the pancreas and the lung, people can have disease or the rectum, people will have a stabilization for maybe 2 or 3 years. It depends on each person. It's not exactly perfect, but it's roughly in that range. So if you can get a good several years out of it, that's actually an effective treatment. And so I know a lot of people are getting it. There was a long time where we could not get it here in the United States, and so we only I had to ship people over to Europe to get the therapy done. But now it's pretty widely available, and it is quite safe, and people do quite well. But at the same time, you can only give it a certain number of times. So you don't want to start shooting your bullets off at the very, very beginning, because it may not be the right thing to do. Okay. Then there are these other medications you can give. These are called targeted therapies. One is called everolimus, or the trade name is called Afinitor. And another is called sunitinib. The trade name is called Sutent. And these are medications that you take every single day, and they help to just kind of tamper down the disease so it doesn't grow quite so fast. Because that's really that's all they do. They just stabilize the tumors. Very rarely do they make the tumors shrink or go away. They almost never go away. But there are risks to it. There's side effects. There's a whole anyone on it knows there's a long list of side effects for each of the medications. And for sure, 100% of the time, there's always treatment failure. The disease will always progress beyond it. So all you're trying to do with these two types of medication is you're trying to buy time. You're trying to buy time, either delaying it for some reason or slowing things down. So that's what you're trying to do. And then, of course, there's always good old chemotherapy, right? It's still a cancer. In general, neuroendocrine tumor is not that well treated by chemotherapy because, chemotherapy is a poison. Let's just be frankly honest, right? And so our medical oncology colleagues are experts at that, but they are chemotherapists, right? And so it is a kind of poison, and they tend to be very, very good for extremely aggressive cancers, your lung cancers, your pancreas cancers, your brain cancers, your bone cancers. Those kinds of things that are aggressive, those are the ones that actually respond best to chemo. But at the same time, even for our neuroendocrine, there are some neuroendocrines that respond very well to chemotherapy. Sometimes they shrink, sometimes they stabilize. And so there is some benefit to these chemos. But again, you have to think about it. And the chemos we classically use are called capecitabine or temozolomide, something called CAPTEM, the combination. Sometimes platinum is what we give, carboplatin, cisplatin, we use those. And then another one called etoposide. So these are the ones that we will classically use. People may use other types of things as well too, but these are the ones we use the most often. But there are risks, they are poisons, right? And so there are major side effects, there's major toxicity, and of course, eventually, they always progress through it, right? So there's always some when they start to fail. So again, it might be the right thing to do at the right time for the right purpose and the right disease and the right person, okay? So always those kinds of things you want to think about. So to be just summarized in one sentence, the art of neuroendocrine is not what to do. The art of neuroendocrine is when to do it, right? And that's what becomes very difficult and complicated, right? Because remember the web I told you about at the beginning, the web of neuroendocrine? Well, this is the web that your doc has to think about. So he or she will open this book, and this is, you can do this, you can do this, you can do that, you can do this, and this is what it's like. This is what it's like to read through what are called the NCCN guidelines, which is kind of like the holy cookbook. What do you want to call it? I don't know, that's a bad example. But it is kind of these pathways for how to take care of various kinds of cancers. And it's an amazing document written by amazing people. And but it's complicated. And so you can see this is what it's like. And so the problem is, for example, if you have neuroendocrine, well, you can do this, or you can do this, or you can do this, or this, or this, or this. That doesn't tell you what to do for Mr. and Mrs. Jones who's sitting across from you right now, right? So maybe they have more liver disease. Maybe the disease is very slow. Maybe the disease is faster. Maybe they have this, maybe that. So it doesn't tell you what to do. And that's really the problem. It just tells you what you can do, and it doesn't mean it's right. So that's why having the right neuroendocrine specialist on board, understanding what you're trying to achieve, understanding what all those therapies do for you, it's then and only then that you can have a good conversation and really come out with a good plan. And I feel very, very true about this. I mean, for those of you who've been to my office, you can see it is like a zebra exploded inside here and decided to give off the spawn of even more zebras on the walls and stuff like that. So there's a lot of zebra stuff here, and I appreciate it. Don't get me wrong. I'm not insane. So to make sure you know, these are all gifts. And so I really feel very, very fortunate and very proud that people bring these things because hopefully it means they appreciate what it is we do. But the zebra analogy really makes a lot of sense. So for those of you who aren't familiar with it, zebra is kind of like the mascot for neuroendocrine. So you may have seen the little bracelets and stuff like that. But what it is in medical school, we're taught or whatever, nursing school, or whatever school you go to, if you hear hooves, think horses, not zebras. That's the line. And what that means is if someone has a cough, right, you should think about allergies, or you should think about bronchitis. You shouldn't think about tuberculosis right away. Because when you're a student, you have no context. You have no idea. You just keep reading about diseases and, oh my gosh, I must have multiple sclerosis right away. No, that's not true. However, every now and then, a little diarrhea, a little flushing, a little asthma, a little abdominal pain, a little this or a little bit of that can be caused by something really weird like a neuroendocrine tumor. That does make you the zebra. And actually, it actually works even better than that, because you can see here, all the zebras have very different stripes, right? All the zebras look very, very different. And so that is very true, because I tell people all the time, the one patient that walks in, even if they have the same disease, will be completely different from the one that just walked out. So when you understand that you cannot treat these people like a cookie cutter, then that's when you begin to understand how important it is, how careful you have to be to take care of people. So let me just go through some general principles and summarize a little bit of sequencing. So the question is, ask yourself, what will kill the person the fastest? Okay, how can I prevent this person from dying? Okay, so I have to figure that out, and then what treatment works with that, right? How do I fix that problem, right? You got to fix that problem. If someone is bleeding every single day, they're not going to survive that, right? What will hurt the person in the future? Okay, so they're actually in pretty good shape right now, but what's going to happen in a year or 6 months or 4 years? Can I do something to prevent that problem now? Like that tangled up intestine, right? If I leave that in there, that person's not going to be able to eat, they'll lose weight, and they will die. That's just how it works. How do I prevent that problem? Well, I can maybe do some surgery and get that chunk of entangled bowel out and untangle the bowels. How will my therapy hurt the patient, right? So that's important. So if I do an operation and I hurt the person, I have not helped that person at all, okay? So I have to be very careful, because what if you do a chemo and their bone marrow is destroyed and you can't have anything else, right? So how many times can I use my therapy? If I can do surgery, I know I have done surgery in some of the people watching this sequence, this webinar, multiple times, right? Multiple times. And hopefully they're actually doing pretty well. So how many times can I use it? How many times can I repeat an embolization? How many times can I go back to a somatostatin analog? How many times can I use the PRRT, right? So those are things you want to think about, because you want to space them out over the course of many, many years if you do your job correctly. And then here's another important one. If I use one, will I burn a bridge? So if I use some kind of a chemo and I burn out the person's bone marrow, will I not be able to give them any Lutathera PRRT in the future? So I'm not saying you can't, it's just that you have to think about that, right? Something to consider. And of course, I always say, can I work with someone with more knowledge on neuroendocrine tumors? I mean, that's not me, but like if you were a community oncologist. So I'm a community doctor, right? I don't work at a university. I don't have some fancy title. I'm just a clinician who takes care of people. So, and many of my colleagues, we work very closely together, because the truth of the matter is, if you had lung cancer or colon cancer or pancreas cancer, I would just be a regular surgeon. I would do the operation. I would hand them right back to the oncologist. But in this case, especially here in Denver, so, I was teasing about my clinic, but I'm very, very blessed and fortunate. I work with a lot of amazing people. The whole hospital understands neuroendocrine. So that means not only the doctors, but the anesthesiologists and the radiologists and the nurses and the med techs and the people who run the MRI machine. For those of you who had an MRI with me, you know that they know how to do this correctly. The ER docs, they understand these things. So if you go to a hospital where they don't understand all these things, sometimes it can be a little complicated, right? So it's always nice to have that kind of thing. And then I work with many, many people. So it's always good to have a team who's familiar with neuroendocrine tumor as part of your treatment team. Okay, but when it comes to actually picking therapies, right? So if you can cut it out, I do think you should cut it out. Really think hard about it. Again, it's not perfect. Not everyone needs to have surgery as their first kind of out of the chute. But for neuroendocrine, frequently it is one of the most important things after you finish the whole workup, right? And if you're not really sure, you should maybe ask someone who knows how to do it to cut it out, right? That might be something to consider. And then if you're having terrible symptoms, frequently the somatostatin analog, so the lanreotide or the octreotide, can be extremely helpful. If the disease is very aggressive, then yeah, it's true. They may need the chemo. That may be their first go-to. If the disease is progressing on a somatostatin analog, you might have to throw some of those pills on, these targeted therapies. If the threat is just the liver, maybe you want to do treatments to this liver-directed therapy, so treatments that are focused on keeping the liver tumors at bay, right? And then if the gallium's positive, then you want to consider the Lutathera RRT, right? So that's always something to have. But you can see here, it's if this, if this, if this, if this. So it's not like you can say just step 1, step 2, step 3, step 4. It's like, how do these things go together? So that's why really a web of treatment. And the reason I know this, let me just tell you a story. So Cindy's on board. So Cindy Lovelace is the leader of the Healing Net Foundation, which she and I put together many years ago. And we have this foundation. I mean, it's the foundation. So I'll tell you about it in a second. But it is also, what we're trying to do is we're trying to bring people together to think about neuroendocrine differently and to think about it as a team. And one time I put about like 8 or 9, world-class neuroendocrine specialists together. And I said, hey, folks, I want you to come up with pathways for me because that's what we do in oncology. So come up with pathways. So they sat there for like 5 hours. Cindy, I can't remember, like 5 hours. And they came up with nothing. And I watched them and I was like, clearly this is not what we do. And they tried. They said, well, maybe this and this and this. But they realized that because every zebra is so a little bit different, you have to approach them differently. So there is no pathway to it. There may be some generalities. Maybe you want to start with, scans. Maybe you want to observe for a little while. Maybe you want to start with the somatostatin analog. Maybe you want to go to surgery, those kinds of things. There may be some general kind of sequencing things. But each person is so different that I just cannot say there's a sequence to this disease, right? Because as Lisa said, you are a person with the disease, not just a disease, right? And of course, return to number 1 and think about it all the time when all else fails, right? Because usually it does help. Okay, so this is the Healing Net Foundation. Just to let you know, it's a group. It's a little different from LACNETS. LACNETS is a really advanced but support group for the region in Los Angeles, but the Healing Net Foundation is a little bit different. So when Cindy and I got together, we realized, and she's a patient, she'll tell you her whole story, but basically we found out that there was a huge gap. There were the doctors here, and then there were the patients here, and there was a huge gap in how patients were being cared for, right? Because you need the right care at the right time. You got to find the right person who can help take care of you, and there was a lot of missing education, and so we've been doing these we're developing seminars. We developed a book, which I'll show you in a second. We do this summit that we do to kind of bring people together so we can think about it very differently. And so it is an important part of our mission to help you. And we do it through as many ways as we possibly can because we're a small, nimble group, so we try to just address the needs. And you can see probably a lot of faces here you might recognize. For those of you who don't know, this is Giovanna Imbesi. She's right here. She is the founder of LACNETS. So if you're not familiar with it, she's right here in the corner here, right on the side, little blonde thing. And sorry, let me get it right there. And she was the founder. She's unfortunately passed away from neuroendocrine, but she was a real champion and a great musician. And a lot of these people, all they want to do is make you better. And I really consider it a blessing and an honor and a pleasure to work with them. So support LACNETS and support the Healing Net Foundation. Okay, now the one thing we did do, which I think is very helpful, is we wrote this book called The Net Primer. It is a very, very, I like to think, straightforward, easy to digest book. You can go to the Healing Net Foundation website and you can just download it for free. It's yours. And you can read it, you can share it with your healthcare professionals, and they can hopefully easily digest it, and you can get a sense of what is going on. And it has a whole bunch of the different kinds of medications and their side effects and how to take them and stuff like that. So it's a nice little resource. And so all of our doctors and nurses helped kind of put it together. So we're very proud of that. So hopefully it's a good resource for you. And here we are. So we've done this a couple times, and you can see there are a lot of people here. There's like, whatever, 70 of my best friends here. And these are important people who've done a lot of important things to help people with neuroendocrine. And here's Dr. Oberg here, and these are my partners, Dr. Alan Cohn and Dr. Charlie Nutting here in Denver. And just know that there are a lot of people who think every day and very hard about you guys. And so that's it. That's my talk. So if there's anything that I can answer for you, I am available. So I'll leave this up here, and I hope that was helpful, everyone. I hope that was useful. So I think Lisa is going to read questions for us.
Yes. Thank you, Dr. Liu. We're so excited to have you, and that presentation was really helpful. I know Giovanna and I were both very grateful for you for co-founding HealingNet Foundation, and just really enjoyed the work we've done with you, both of us, through the HealingNet Foundation, and we considered you both a colleague and a dear friend. And just thank you for remembering Giovanna today. So just as a reminder, as we go into the Q&A, we're going to try to get as many questions as possible. We have about 46 questions, and we may have edited some of them so they're not so case specific and more instead general to serve the broader audience. And just a reminder that this webinar and the Q&A in general is providing educational information only and is not a substitute for talking to your physician. And you're always advised to talk to your medical provider and seek medical attention if you need it. So one of the things you talked about, the first thing is to go see a specialist. So one of the very first questions that was asked is pretty simple. Are you aware of NET Centers of Excellence in New Zealand?
Wow. So clearly LACNETS has quite a reach. That's terrific. So I am not familiar specifically with New Zealand. We do have a patient who's logged in from New Zealand. I don't know if she still lives in New Zealand. But no, not specifically. But there are a couple that I know of definitely in Australia, which is not too far away, hopefully. The Peter Mac Hospital certainly has that, and there are other groups in Australia. So there are experts in Australia who can definitely help you. New Zealand, I'm not sure about.
Thank you for that. Yep, our reach has been international. So, last year when you joined us, we packed out that room with 70 to 80 people. And so perhaps the silver lining of the pandemic is more and more people can join us here.
Yeah,
so the other thing that you mentioned was step 2 is the complete workup. So I guess at what point, one of the questions that came up is at what point does it become important to follow elevated chromogranulin A levels, especially if there's stable scans?
Okay, so that's a hard question to answer because people feel differently about this. I'll tell you how I feel about it. So I don't love lab markers because I think they are difficult and confusing to sometimes sort out. Let me explain why. There's value to them. Don't get me wrong. There's value to them, but they can sometimes cause more headache and stress for the patient than they can really help the doc. So remember that somatostatin analogs, so octreotide and levothyroxine, both have the ability to suppress the amount of hormone that's created, okay? So no one dies of excessive chromogranin, okay? Just understand that. So if I injected chromogranin into my blood, probably nothing would happen, okay? So that's not what you're looking for. Chromogranin is just a surrogate for what you think might be worsening disease, stuff like that. So you're not gonna know until you definitely get a scan, okay? And the scan is the most important thing. So that will tell you like what's really going to kill you. At least I feel that way. The problem with chromogranin specifically is it fluctuates a lot, right? So depending on when you take your shot, it may fluctuate and you may get different things, and so it'll make you nervous. So I don't go crazy about it. I may check it here and there to get a sense of what's going on. However, there are some that certainly do correlate with how a person feels. So for example, serotonin. So like we talked about serotonin, which we usually think of as being a happy hormone. You take your Prozac and your serotonin goes up, right? But serotonin can cause a lot of havoc in people who have neuroendocrine. We think it can cause problems with the heart. We think it can cause problems with the diarrhea. We think it's associated with the flushing as well too. So the carcinoid syndrome, kind of what we classically call it. So that may be something important to measure, because if you measure it, maybe there's a therapy you can take for it. So for example, there's a medication called Zermelo. Zermelo is a telotrestat is the generic name. Zermelo is a medication that you can take that specifically blocks the ability of your tumors to make any hormone, serotonin. So if, for example, someone has elevated serotonin and has a lot of diarrhea from it, you can perhaps give this medication to help them. And so that's why thinking about all these different options and having a neuroendocrine specialist who's aware with some of these other types of therapies is very, very important. So I don't go crazy about following blood markers. Some people do and will do it, but I just try to talk them off the ledge.
Okay. Well, a follow-up question with that, because chromogranin A is a popular topic, is really why it might move up suddenly after years of being normal.
Okay, so the most common reason that happens, I see that all the time. So the most common reason is that either one, your doctor changed laboratories, okay? And I hate to tell you these dumb, stupid things, but it is so true. The laboratory that your doctor used to use, the normal was from 0 to 5, so you were at 3. And then all of a sudden it jumps to 75. But it turns out they changed laboratories and their test is now 0 to 95. So just watch out for that, right? Sometimes people start taking a medicine called a proton pump inhibitor, like Nexium, Prilosec, Protonix, those kinds of medicines. They artificially elevate chromogranin. And since pretty much everyone takes those kinds of medicines nowadays, their chromogranin becomes difficult to follow. So understanding what's going on and knowing what's happening, those are all things that are important to evaluate when it comes to a tiny little number.
Okay. So if it jumped from normal to 400, would that trigger you to want to change the treatment plan?
Well, it depends. So if the normal is like 397 and it went to 400, then I probably wouldn't freak out about it. But if it really jumped, really truly jumped from 0 or 3 to 400, then it might do is just speed up the time that you get a scan.
Right. Okay. One more question about chromogranin A before we move on is, would eating food high in amines cause a higher reading?
I don't think so. So there are certain foods that affect your tests. The most classic one is something called 5-HIAA. It's that urine test most people do, which is now available as a blood test. So if you get it as a blood test, it's only done by one laboratory called InterScience Institutes in Los Angeles, near you guys. And they do a plasma or a blood version of 5-HIAA, so you don't have to pee into a cup for 24 hours. That's really where those foods can cause problems. But in general, it doesn't usually change the chromogranin. So I think you're probably okay.
Okay, thank you. So another question with the workup is, what IHC stains or techniques do you recommend for identifying a primary source when you couldn't find the primary source during surgery?
So yeah, that can sometimes be a problem because sometimes neuroendocrine tumors, so unlike other kinds of cancers, sometimes what happens is the neuroendocrine tumor can be very, very, very small and it shoots out and you get all this disease, okay? So it's a little bit different than what we normally think of. Excuse me, put the thing back up, the text back up, Rich. So if you look at the bottom, so the question is, what is IHC? So first, IHC is something called immunohistochemistry, okay? Immunohistochemistry are the stains and the colors that they put on the little slide from the biopsy. So we do a bunch of different IHCs to help figure out what's going on because there's like a biological signature that comes with each of the tumors. And so classically for neuroendocrine, we always stain something called synaptophysin. It's almost the definition of neuroendocrine. And then we'll stain for chromogranin as well too. Excuse me. And so those are things. But when you try to figure out the primary, there are multiple different types of things that you can do. You can send for different kind of cytokeratins. This is a little bit in the weeds. Different types of cytokeratins, different kind of transcription factors. So those are things that can help. But at the same time, you don't want to exhaust the block. There is a test called cancer type ID. And it is actually almost like a genetic kind of a test that looks at the genetic profile of that tissue and can sometimes give you a sense of where the tumor comes from. Again, they're not perfect. Usually the much better thing is a doc who knows what to look for, a good gallium dotatate scan, and probably a good operation. So those are probably the things that will help you the most.
Okay. So there's a lot of questions about somatostatin analogs. So let's talk about that for a little bit. At what point Does it? Oh, I'm having problems. Okay. At what point? Okay, in a patient without gallstones prior to initiating SSAs, is the occurrence of gallstone development higher for the general population once on an SSA?
A little bit, a little bit. So, gallstones are in your gallbladder, and gallstones are very, very common in the general population. So just understand that. So what happens is when you take a somatostatin analog, what it does, the analogy I always give is it's like a wet blanket. So you throw the wet blanket on your endocrine system and your digestive tract. And so it slows down your pancreas, it slows down your gallbladder. And if it slows down, then the little gallstones can form. So in a patient without gallstones prior to starting it, it's not actually usually the gallstones are the problem. It's usually the function of the gallbladder that becomes a problem. And so sometimes people need to have their gallbladder removed. But I do not routinely remove a gallbladder just because I see it, just because they have neuroendocrine. I think about why I'm trying to remove it before I do that.
Okay, and that actually gets to that question of is a prophylactic cholecystectomy always recommended when performing surgery, and why is a prophylactic cholecystectomy always performed when only a third of the patients on SSA develop gallbladder stones?
Okay, so this is where a little bit of thinking is actually important. So people who take a somatostatin analog, like maybe 10 to 20 to 25% of them will develop some problem with their gallbladder. Usually it's pain, like they can't eat that well. Frequently, the problem is something called exocrine pancreatic insufficiency, which is basically it shuts down your pancreas too, so you don't make enough juice to eat, and so it can cause a lot of pain. The treatment for that is different. The treatment for that is what's called pancreatic enzyme, and there are multiple brands like Creon or Pertzi or Zenpep. You may have heard of those. So that's a different kind of thing. But if your gallbladder really isn't working, then usually the therapy is to remove it. And so people say, well, if you're going to go on a somatostatin analog, you should probably just go ahead and remove your gallbladder anyway. Well, I don't feel that way, right? I mean, if God gave us a gallbladder, he gave it to us for a reason, I think, right? So this is how I approach it. If the person's going to be on a somatostatin analog, and I can get back to their gallbladder relatively easily with a laparoscopic operation, so just the little sticks, then I will leave the gallbladder in. So for example, the patient only has disease in their bowel, and they need a bowel operation, then I'll do their bowel operation and leave their gallbladder in place, okay? But if I do a big, big complicated liver operation in which the whole thing will be scarred down and I'll never get back to the gallbladder again through my little incisions, then I actually will remove the gallbladder because it's so much safer and so much easier to do it. And the reason I know that is because I've done this before. So I've had when I was younger, I had a bunch of patients who had all these fancy operations and they left the gallbladder in, and then I could not get back in to the gallbladder. So I had to open the patient, do a much more complicated operation to get that gallbladder out. So if that's a situation, then a prophylactic, so doing it kind of before the patient has any problems, actually may be called for.
Thanks for explaining that. That's really helpful. And, speaking of surgery, since this is your area, is surgery always recommended as first line treatment for NETs?
No, not at all. Right. Yeah, not at all. So 31 flavors, zebra, whatever analogy you want to use, it is not. So I like to just preach that because that's what I do for a living, right? So I like to preach that, but at the same time, I like people to think about it more because frequently it's just discarded. Because what happens is neuroendocrine is very, very frequently a metastatic disease, which means it's spread already, right? And so traditionally in our kind of oncology care, if it's already spread, there's no role for surgery. But that's just not true in neuroendocrine. The surgery can help people a lot. So, I try to joke about it a little bit, and I like to just make sure people think about it, but it is definitely not always the first thing. It is not always, many of the people watching this have sat in front of me and I said, look, you don't need surgery today. You might need it in the future, but you don't need it today. And so that's what you have to figure out.
Thank you for that. And another surgery question, when is a NET patient not a candidate for surgery? For example, the location of the tumor, if it's in the mesentery, or perhaps a heart condition that might exclude them.
Yeah, so that's extremely, extremely difficult and extremely complicated to figure out. So if there's some kind of a heart condition, that might be true for anybody, right? Hernia repair, it doesn't matter at all. So that's something that has to be considered. Sometimes they're not a candidate for surgery because, yeah, right, the tumor is stuck someplace where if you do the surgery, you will kill the patient, right? I mean, I've had that situation before. Like, oh, if I mess this up, the risk is so high, it's not worth doing. And then sometimes it's just not worth it. So, for example, if a person has 1,000 tiny little tumors inside their liver, I can pick out a lot, but I can't pick out 1,000. So maybe it's just not worth it to do it. So those are the kinds of things that require kind of careful thought and education. I'll give you an example. So frequently, so I told you neuroendocrine tumors can be, bask in 31 flavors. But the better way to think about it actually is that neuroendocrine tumors actually exist on what's called a spectrum, okay? So you have a spectrum of different types of neuroendocrine, from maybe like very, very quiet and well-behaved to extremely aggressive, okay? So sometimes people have really, really well-behaved neuroendocrine tumors, and they're just like little growths, so more like freckles than they are like skin cancer. So think of it that way. That's just an analogy. And sometimes you can, just pluck those things out and the person will be fine. Sometimes you don't even have to pluck them out because the risk of the operation is so high that you don't have to do that. But you need to see a neuroendocrine specialist to really know who to, to sniff out who can sit and who can't. And those are the kinds of things that we have to kind of help you through.
Yeah, that's a really good point. I mean, you really need to see a specialist. And speaking of that spectrum of flavors, is it possible for someone's tumor grade to change over time? And for example, could a low grade change to high grade?
Well, that's actually really interesting. So for the people who aren't familiar, so grade is basically like how aggressive the disease is. There are two ways that neuroendocrine can be aggressive. It can either spread, or it can grow, or it can spread and grow. So grade kind of gives you a sense of like how far the gas pedal is pushed down. So it's kind of like grade 1, grade 2, grade 3. Grade 1 is the not too bad. Grade 2 is the ugly. No, it's like the good, the bad, and the ugly, right? So grade 1 is good, grade 2 is bad, and grade 3 is ugly. So usually the grade 3s are very aggressive. So when people say does it change over time, I don't know the answer to that question, because usually grade is determined by a biopsy. So you take a teeny tiny little piece of the tumor, and you just assume that teeny tiny little piece represents all of your disease. That's just not true. It gives you a sense, but it's not true. It's a little bit like going to a school, picking any random child and basing like the quality of the school on one single child, right? So that's just not how it works. The only test that absolutely works all the time is the test of time. So you have to follow these patients over time to figure out what's going on. So when someone says, well, the grade of my disease changed, I was like, well, yes, I guess that can be. Or it can be really that one of the tumors was a little bit different from the other tumors and it grew faster. And the biopsy they took was from a low grade one, when in fact there was like one that was high grade and behaving differently, right? Because I told you, you can have different zebras even within the same person. So that's where it becomes complicated. So I can't really answer that question for you because I don't know if it really changes, because I can't biopsy it 1,000 times over the course of your life to know whether or not it's really different.
And as you said so well, not all tumors are the same. So another similar question is, can a non-functional NET tumor become functional over time?
Oh yeah, that is for sure. That can for sure happen. Okay, so let's get to Lisa's question about, first of all, what is functional and non-functional? So neuroendocrine tumors, like I told you, endocrine, right? So they secrete hormones, but not all of the hormones that are produced actually torture you, okay? So chromogranin, for example, it's not really a hormone, but it's a protein that comes out, but it doesn't do anything. It doesn't torture you. Whereas if you had a tumor that produced insulin, that would torture you. If you had a tumor that secreted a lot of serotonin, that would torture you, right? You get all these symptoms and syndromes and stuff like that. So in general, functional neuroendocrine tumors are the ones that kind of produce these classical kind of group of symptoms called the syndrome, like carcinoid syndrome, the flushing and diarrhea, versus non-functional, which in general, they just sit there, right? And they may grow, they can cause problems, but there's no question that they can change over time. And so in general, if you start off with a somatostatin analog like lanreotide or octreotide, you can suppress all those hormones and keep things down. And once you kind of keep things down, then usually people are in pretty good shape. But then again, sometimes the treatment can't keep it always down. So that functional may get worse. Sometimes there are some of the treatments, for example, I've had patients who have had the Lutathera, and they went from a totally non-functional, at least what I thought was non-functional, to a rapidly, terribly functional tumor, and they died of the hormone. So it's complicated. It's complicated. The answer is yes, it can happen. And usually when they become functional, they become more angry. So it's something to watch out for.
Yeah. Another interesting question, actually, this is a couple of questions together, is NETs in the brain unusual? And if it's not unusual, would a gallium dotatate be the scan of choice? And then also, once it's found in the brain, would it be more likely that there's more brain tumors that would surface?
Well, that's actually really interesting and complicated. So in general, you hear me hemming and hawing because everyone's different. But in general, brain tumors are very uncommon for neuroendocrine, for the classic kind of things, small bowel, pancreas. They don't usually happen. The place they do happen generally tend to be with lung neuroendocrine tumors, kind of generally. So you kind of have to kind of watch out for that. Sometimes the rectals can also go to the brain. Rare, but they can. But it's mostly lung. And in those cases, you should get all different kinds of scans. You should get brain MRI, you should get a gallium scan. You may even consider getting the standard FDG PET scan. So those are all things that might be necessary in order to figure things out. And in general, with the brain mets, I don't actually cut them out. So that's a different situation. I usually actually treat them with external beam radiation therapy because they can tend to bleed. And so I'm always a little bit nervous about these brain metastases.
Yeah, thanks for that. There's an interesting questions about asking your thoughts about off-label drugs in treating NETs, especially the use of metformin, cimetidine, mebendazole, etc.
Yeah. So that's really interesting. So the answer to that question is I just don't know. I mean, it's great. It's fascinating. I just have no idea. So the three that are listed here, okay, is metformin, which is a very classical diabetes drug, does have maybe some activity in cancer. Look, don't get me wrong, it's no chemo. It doesn't cure cancer, but it might be helpful. Cimetidine, which is one of the anti-acid H2 blockers, might have a little something through some secondary effects. Mebendazole, which is an anti-parasite medication, actually is slowly being studied. So I think the answer is probably they have, they probably have some kind of function. But since no one studies it, I just don't know for a fact. So people ask me all the time, like, well, if you want to try it, I can't guide you, but you can try it. And I'm open-minded to it.
Okay. And also, with SSAs, is there proof that SSAs can slow tumor growth to start treatment in an asymptomatic patient prior to evidence of disease progression?
Well, that's an interesting question. I don't know. So people feel very differently about that. I have a friend who actually lives here in Denver now. He's an old doctor named Dr. Warner who used to work at Mount Sinai. And I asked him that question, and he feels very strongly that starting the somatostatin analog changes the biology of the tumors. Now, he was around before their somatostatin analog, so he was grateful when it showed up. But I will tell you, there are some other docs, and there's one doc who was very much influencing my thinking, is that sometimes you don't need it because the tumor is so slow. And you may get away without having to have a butt dart every month for quite a long time. And so I do have some patients in which we watch them for years and they don't progress at all. And they don't have any treatment at all. I always worry, and we always may scan them a little more frequently. So there is definitely some possibility that you don't have to start a somatostatin analog right away. But again, you should probably do that under the guidance of a neuroendocrine specialist.
Mm-hmm. Speaking of somatostatin analogs, is there a different result in tumor growth between sandostatin and lanreotide?
I don't know the answer to that question exactly. They've never been compared head-to-head, so I can't really tell you. All I can tell you is that sandostatin does not have an indication for tumor growth, so the FDA has not approved it for that. However, there was a very well-known research study called the PROMIT study, which demonstrated that sandostatin LAR does gently slow down the growth of slow tumors. Lanreotide does have an indication for the growth of tumors. And don't get me wrong, look, it's not super powerful, okay, but it's a very good medication because if you have a very slow disease and you have a very tolerable medicine, they kind of go together, right? So I don't know. Sandostatin is sometimes absorbed better by certain people. Sometimes the administration can be very difficult. Lanreotide is a little bit absorbed a little bit more reliably, but it may not have the same effect because it's a different hormone. So it kind of depends on what you do. So at least but again, it's always better to have more options than less options.
Yeah. And another question about somatostatin analogs. How soon after starting the sandostatin might a patient notice less symptoms of flushing and diarrhea?
So if someone really has carcinoid syndrome of flushing and diarrhea, then the problem is you want to get it going. So the sandostatin 28-day injection LAR 20 milligrams may not work right away. So you're much better off taking the rescue medication, which is the little insulin, kind of insulin needle that you give yourself. We call it rescue. It works right away, like in 15 minutes. But the only problem is it only lasts for 4 to 6 hours. So you have to give yourself the shot over and over and over again. There is a new version of it. It comes like almost like an insulin pen called Benfenzia. You can kind of give it to yourself and go boop, boop, boop. And so it's a little bit more convenient. So you may need that in addition to the sandostatin to kind of get yourself ramped up. Because I usually tell people it takes about 3 days, 3 shots before they get really ramped up. So it may take up to 3 months before someone really gets good control of the disease. But again, you may need other things too, right? So if you're still having diarrhea with your sandostatin, you may want to try that Zermelo medication. You may want to make sure you have surgery. Maybe you have embolization. So you got to put all these things together to get the best plan.
Yeah. And I just want to highlight a couple questions for high grade. How do you find a specialist for high grade NETs? It seems like there's less, I guess they feel like there's less treatment options since most of them don't express somatostatin.
Yeah, that's a fact, unfortunately. I don't know the answer to that question because neuroendocrine carcinoma, which is really high grade, the good, the bad, the ugly, it's the ugly. It is brutal. It is brutal. And there's a really great Facebook page that's run, the high grade neuroendocrine carcinoma page, run by Susan Sylvan. So that's a good resource. But it is an unmet need. I wish all my oncologists would forget all this low-grade stuff and just focus on the high grade because that's what kills them. I can keep low-grade people alive for a long time, but high-grade stuff just kills people right away. So I wish we had more for it. So I don't really know the answer to that question. But obviously seeing neuroendocrine specialists is still a good way to go. But in that case, you should see a oncologist.
Mm-hmm. And what treatment options, if you know, are best for this group?
Well, there's no question chemo is the best for that group. I mean, sometimes they need surgery because they have problems, but chemo is usually the best way to go. And usually we start off with a combination of platinum and etoposide. It's kind of our go-to. It comes from actually lung cancer. It doesn't always work, but there are various combinations of chemotherapy that we usually give. Sometimes the CAP-10 can work, things like that. Sometimes there are other kinds of chemos, but there are like so many, there are like a zillion different kinds of chemos now that I really wish that we could start to test some of them in neuroendocrine because that would be a new tool that we need. The immunotherapy is encouraging. I'm not totally sure it works yet because there have been some small studies saying that it's not perfect, but people are trying that as well too. So, you know, there's always things to try.
Yeah. And thank you for answering so many questions. We'll just take one last one. What supplements would you recommend for NET, the population?
Well, that's actually more complicated than you think. The supplement field is complicated to begin with, right? So I'll tell you, right? I mean, like I take, just personally, like vitamin D, I take B complex, and I take some magnesium, right? And those I think are things that like really easy things to help people. However, for neuroendocrine specifically, it can be a little bit complicated because people have had surgery, people have electrolyte losses. People have all kinds of different issues depending on what their disease, how their disease behaves. So in general, the easiest thing is to say, yeah, be healthy, eat a good balanced diet. The more color there is in it, the better. Reds, greens, blues, oranges, you know, whatever you can get is good. Some people can't tolerate salad, right, because of their surgery or whatever. So just, I understand, just be careful and thoughtful. If anyone's interested, actually, there is a neuroendocrine cookbook that was actually produced by one of the sponsors, Lexicon. So if you go there, you can probably get one of the cookbooks, and that would be a little bit of a guide. But anyway, so as far as supplements go, sometimes people need more B12. Sometimes people need more iron. Sometimes people need more calcium. Sometimes they need less calcium. Sometimes they need more potassium. So those are all things that are important, which are certainly not going to hurt you, but are things that you should consider. And in supplements may also include things like laxatives, right? So maybe you need like daily laxatives to kind of keep things going. And so those are all things that you need to talk to your healthcare provider about.
Thank you for that, and thank you for answering all these questions and all the helpful resources that you've thrown out. Definitely with the Healing Net Foundation, the cookbook, the Facebook group for the high grade, just the collaboration and teamwork of all the doctors and medical professionals and just people, the allies that are out there for this whole net community. And thank you for being one of them. We really appreciate all you do, all your hard work, and keep doing what you're doing.
Oh, you're welcome. So, hey, let me tell you a story about Lisa. So, we went to we had one of these summit meetings in San Diego, I think, and she and her husband came to the meeting. And one of the things that was decided was that we really need to produce some kind of document to help you describe your disease. And so she and Giovanna and LACNETS kind of took that idea from the summit, and they ran with it, and they created that Net Vitals thing. So if you go to their website or wherever you can download it from, you can download Web Vitals. It's actually a very helpful tool to kind of summarize your disease and help your doctors. So, Lisa's role in neuroendocrine should not ever be underestimated. So thank you, my darling. You did a great job. I appreciate you.
Well, thank you. And that comes from collaboration, from these discussions, the open discussions we keep on having about neuroendocrine and the issues and concerns that we have and how we can conquer them together, right? So we are a team, and I really appreciate all you do for this team.
Okay, everyone.
So thank you.
Take care. Good luck. I hope this is helpful. Remember, there are a lot of people who are out here to help you. So, sometimes you have to be you have to be the head chef or the captain of your ship or whatever you want to call it. It's not always fun. It's not always fair, but there are a lot of people who want to help you. So get out there and just take control of your disease.
Great. Thank you. And I'll turn it over to Lindsay now. Have a good day.
Thank you so much, Dr. Liu. That was an incredible presentation. I'd like to thank our sponsors one more time, Lexicon, Ipsen, Sun Pharma, AAA, and Novartis for making this possible. And remember, our next live webinar will be on August 28th, and it will focus on our health coaching program, August 28th at 10 a.m. Pacific time. And don't forget to follow us on social media, on our Facebook page, Twitter, and Instagram at LACNETS. Stay up to date on net news, announcements, and events. Thank you so much. We hope you have a great weekend, everybody. Thank you.